Thank you for your interest in VELscope. Of the tens of thousands of VELscope users, of family members as we call them, we've had the fortunate experience of sharing numerous stories where VELscope has literally assisted in saving lives of patients. What we found, though, through the process of enhancing the screening process and ultimately the most beneficial aspect of utilizing this technology, which is saving lives, there's an added benefit, which is the enhancement of the value of the practice, of how the patient perceives the clinician, that elevates that practice and those clinicians above a standard practitioner. We're going to talk about oral cancer, but I want to stress this is not about cancer. This is about prevention. The only way to prevent any form of cancer is to find it at a precancerous state. The challenge is, unfortunately, with oral cancer, it's predominantly found at a late stage, which is why the survival rate has not changed in over 35 plus years, still hovering around 50% survival rate. So as we've seen this 50+% increase in oral cancer over the last 10 years, we're obviously unfortunately seeing a higher level of mortality. As we see this slope, though, see how much more dramatic it's becoming, even though smoking's declined. And so I would ask you to think about, what is your thoughts? What do you think are some of the top 10 cancers? Your patients will definitely say breast cancer, lung cancer, colon, cervical, skin. I feel very confident no one ever put oral cancer in that category. But using a comparison to what many females will say, there's 4 times as many oral cancers as cervical cancer. And I really stress that we consider this comparison for a couple of reasons. First and foremost, over 50 years ago, cervical cancer was the leading cause of death among women. A simple screening process was initiated, the Pap smear, and now cervical cancer is ranked in the mid to high 20s. Second, though, is the cause of cervical cancer. Most people are aware that the leading cause of cervical cancer is the HPV virus, or several strains of the HPV virus. For us now, or specifically in the dental world, HPV now is the leading cause of oral cancer. The CDC has come out with a extremely strong statement that 70+% of all oral cancers are caused by HPV 16 and 18. 7-0. This is no longer a smoker's disease. And this is very important because many of your patients will believe that, oh yeah, I'm not a smoker, so I'm not at risk. It does not matter anymore. It's one of the reasons why we've seen the age, unfortunately, of oral cancer patients decline. So we're seeing patients in their teens now get oral cancer, which was unheard of 20 years ago. So as referenced, the CDC in their statement specifically focuses on HPV 16, but the studies are now showing HPV 18 is also a leading cause. And so the question to you is, how do you know who's infected? I've had conversations with OBGYNs, and they've said that they believe 70+% of their patients are HPV positive any given visit. 7-0. So if the majority of patients are HPV positive, female or male, how do you determine who's worth screening? And the thing is, we stress, because of this high rate of infection, it's important to assume everyone's at risk, regardless if they're smokers or drinkers or cancer histories and so forth. Another thing that we're really stressing to our practitioners is that studies are showing that women that have had abnormal Pap smears are actually at a higher risk for oral cancer. 35% of all women have had an abnormal Pap smear. So 3 out of 10 women that you see that are obviously adults actually are at higher risk for oral cancer. Very important information to share with your patients. So as referenced, unfortunately, the majority of oral cancers are found at a late stage. Unfortunately, that stage, when it's found at stage 2 or greater, makes it very difficult to have a high survival rate. What we've done and what's important to understand is we allow you now to focus below the surface at the basement membrane where those abnormal cells begin. And by identifying those abnormal cells at the basement membrane, we can catch them now at a precancerous stage, which hopefully then we can avoid from getting to a cancerous stage. So the VELscope technology, again, has been out for many years. Our latest version, the VELscope VX, which is handheld and portable. But the technology actually comes from utilizing it for lung cancer screening. About 20 years ago, it was developed for that. And the technology has been modified for oral mucosal examination. But it's really important to understand, this is a screening technology. This is not diagnostic. Just like a mammogram screening. A mammogram identifies abnormalities and further assessments required. So with that, if we see something abnormal, we go through a process of assessment we'll go through in a minute. But it's important from strictly the screening process itself. It's simple, it's easy to use, it's a safe blue light, so it's not like a curing light, so you don't have to be concerned about damage to your eyes or to the patient. There's no radiation, there's no stains, there's no rinses. It literally is a simple light that we look through the handpiece as we're directing it to the oral mucosa. And when the tissue is normal and healthy, predominantly the collagen in the basement membrane responds and actually absorbs the blue light and gives a response, which is called fluorescence. We capture that response through the handpiece, of which when it's green through the handpiece, that indicates that everything's normal, which is what will be the case in the majority of patients. When there's something abnormal, and that's all we can say it is until biopsy, but specifically if it's dysplasia or cancer, it cannot respond. It can't give off, it can't fluoresce, and so then it appears dark or black. It literally is that simple. So looking at some examples, here we see something you may or may not be concerned about. It looks like maybe a little scar, might lead to a question of the patient. Mrs. Smith, did you jab yourself back there or something? You might think it's just a scar associated with the wisdom tooth removal, but now under VELscope, we clearly see an area of concern. We don't know what it is, and that's all we can say, but we apply a process of assessment. It's unilateral, it's a regular shape. It persists for 2 weeks. We'll talk about an additional technique. When we rubber cross it, it stays dark. All of these pieces help us understand this is something that now needs to be referred, and upon referral comes back as CIS, which is fantastic. So we caught this at a stage before it's full-blown squamous cell, which means we avoid the radiation, the chemotherapy. Here's an example of a lesion. You can see a polyp. Under VELscope, the polyp is actually green, which tells us it's benign, but it's actually the adjacent area that shows up as abnormal, which was then confirmed as CIS and dysplasia, which is fantastic. These lesions we see every day, and this is the daily benefit, I would say, to using VELscope. It's not to find oral cancer because we're not going to see that every day, but all the lesions we do see, we're going to provide more information to provide further direction for assessment. So this is an example actually of a study in which we were looking at leukoplakias, and this leukoplakia was in observation mode for over 2 years, but under VELscope, we're saying we're not observing anymore. Again, unilateral, regular shape persists for 2 weeks, clear defined margins, what says we need to refer, and fortunately caught this at severe dysplasia, which means we're not going to lose half our tongue. But fortunately, the reality is most of these lesions are actually going to show up as benign. Hyperkeratosis, lineal lichen planus will show up as green or light green in color, which I will stress does not mean we ignore it. It means we need to figure out what's going on. Is it a sharp cusp? Is it an allergy? Is a patient biting on their tongue? If it doesn't resolve, whatever doctor you feel is warranted, 6 months, 12 months, we should always refer. That's standard protocol, but you're referring with a strong sense the lesion is benign. So one of the extremely positive things about fluorescence, or specifically the safe wavelengths that we use, is that hemoglobin absorbs this wavelength. So what does that mean? That means that trauma and inflammation will appear a darker shade. And I say shade because once you see it a few times, you'll get a sense of it probably is inflammation or trauma, but we always stress you want to always follow the process of assessment. And that is when we see something abnormal under the VELscope, we want you to take your Explorer or turn your mirror around and gently rub across it. And here, as the hygienist rubs across, if you notice, it turns green. And so what we're doing is we're pushing the blood out of the epithelium and seeing that nice, healthy collagen in the basement membrane that tells us specifically this is a denture sore. If this stays dark when we rub across it, that elevates our concern that says we definitely need to have this patient come back and reaffirm that it doesn't blanch. And at that point, then we would refer appropriately. So this is a phenomenal technique to assist you in confirming things that you see every day are just trauma or inflammation. So one of the questions that comes up is, is this going to increase my liability? If I use VELscope and I miss something, am I now more liable? And I can tell you it's the absolute opposite. We've made a recent announcement, one of the largest brokers, specifically through an insurance company called ProAssurance, is actually reducing their malpractice premiums for VELscope users because they've been able to show that even though misdiagnosis of oral cancer is the #1 average payout, close to $4 million, unfortunately for misdiagnosis, VELscope users can significantly reduce that risk. So VELscope will reduce your liability. I think that's an example sort of that how we can reduce that. So this patient was referred to NYU for the hemangioma in the lip. And when they were referred to NYU's oral medicine department, you clearly see under VELscope this area that was missed by the clinician who referred. Fortunately, this hemangioma was there that warranted the referral, but if it wasn't, would this have been caught? You're not missing this. VELscope increases your sensitivity by over 62%, meaning you turn on the VELscope, you look through it, and you point it at the tissue, it's going to be highly unlikely that you miss anything. But I'll stress, even if you did, it doesn't matter because VELscope is part of your white light examination per FDA indications. It doesn't replace it. So therefore, if you follow your protocols, both in terms of the process of examination as well as documentation, that is ultimately what provides protection for you for liability purposes. So a few more pictures. Here we see under VELscope, a dark area that isn't readily apparent under white light, and this is the dysplasia. So again, this is what we're trying to identify. This is actually from University of Washington, Dr. Ed Truelove. It was part of a study that they participated in that showed that students using VELscope were more effective in identifying and triaging abnormalities than the oral surgeon, oral pathologist, and oral medicine practitioners. Another quick example, and this is one of the reasons why we always stress you want to have the patient come back after 2 weeks, because here's an example where a clinician saw something under VELscope. It appeared to be a white lesion visually. After 2 weeks, the white lesion was gone, but under VELscope, that lesion is still there. And this is a squamous cell carcinoma. And I think one of the things that's so important to stress and why the detection rates are at such a, unfortunately, late stage, because it's really difficult to identify these lesions. Here's an example of a patient. This was sent to us by a world-renowned oral pathologist that was pretty amazed because under white light, now obviously this is someone who's extremely sensitive at screening, saw something clinically, but under VELscope, found something clinically. And we can clearly see an area of abnormality under VELscope that isn't readily apparent under white light. And this is already a carcinoma. So again, this is a carcinoma as opposed to, it would have been nice to find this in again, precancerous stage. So when we launched VELscope, one of our biggest challenges was you would see something suspicious and you send it to a specialist, an oral surgeon, ENT, and they would say, we don't really see anything. We don't feel comfortable taking a biopsy. And then you're in this gray area sometimes of what do we do next. And so throughout the years, we've developed a variety of different techniques for photo documentation. Our latest one is using an iPod Touch that attached to the back of the VELscope. There's an app that you download that now specifically allows us in a HIPAA compliant manner to take images. You can store the images or obviously download those into the patient's chart, but you can compare one visit to the next. And actually there's menus that allow you to categorize the location, the size, the color, and so forth to provide description. And then you can email directly from the iPod if you have Wi-Fi to a specialist if it's so desired. Again, all in a HIPAA compliant manner. So one of the biggest questions that comes up, there's so many false positives. And I always stress saying there's some validity to that statement, especially for early adopters, because there really wasn't any training. And so if you're referring everything that's dark to an oral specialist, oral surgeon, for instance, yeah, he's going to say you're referring a lot of these patients unnecessarily. I would stress now that both from a very simple reinforcement of the process of assessment, combined with photo documentation and the blanching technique, you should have a very clear indication if something abnormal warrants a referral. And I stress abnormal. VELscope is not diagnostic, and therefore, technically, there aren't false positives. But what we can say, if you follow the protocols, unilateral, regular shape, persist for 2 weeks, does not blanch, you're going to have a very strong sense that that lesion then warrants a referral. And we pray that those lesions are never cancerous. But at the end of the day, they have a high probability of being something that could be potentially dysplastic. So, as referenced, I think initially, VELscope's been out for many years. And with that, there's over 30 plus studies on fluorescence and VELscope, specifically in the oral cavity. And I'm sorry, this actually hasn't been updated. There's been a couple others that we can add to this. But again, Dr. Truelove had a study back in 2011 associated with the University of Washington that was, again, pretty extraordinary. But as we see additional studies out of Journal of American Medical Association, where they actually showed when surgeons start utilizing VELscope in the process of assessment and excision of biopsies, we're actually seeing a reduction in recurrence because VELscope's guiding the surgeon from removing all the tissue. And this is all on our website for further review. So question always comes, what should we charge? And I think it's all relative. It all depends on where you're at. We've done surveys. Nationally, the average fee is a little over $22. But the great thing is we find that through appropriate training, specifically with our 2-hour certification on-demand course, which does both a clinical review as well as an implementation review, we're seeing a pretty high level of patient acceptance. But specifically for the state of Washington, Microsoft covers for the VELscope. It's the product code D0431 at a price of $60.18. We believe also, and I apologize because there's a protocol apparently in place for Boeing that also covers at an analogous rate. And so when we look at what the costs might be and therefore the return on, if you will, your investment, looking at our standard retail price of the VELscope, which provides all the materials that you need, posters, brochures, there are sheaths and little paper caps that we use at a price of $29.95, obviously factoring the tax benefits, looking at 3 Microsoft patients a day at $60. We're talking about an ROI of less than 3 weeks. It's a pretty significant return. And again, 3 is a low number based on the numbers that we see overall in terms of patient acceptance. So VELscope will provide a return. We'll provide a profit. It's not going to be gigantic, but it definitely plays the bills. And just as importantly, provides an opportunity to share an additional technology that you incorporated, which I think ultimately has much greater value when you educate your patients on what you're doing and why. There's several things that we talk about how VELscope can increase your acceptance of other things that you offer, like sleep apnea, which is pretty exciting, which is the studies that were underway. But just electronic toothbrushes, where you can use this to assist in getting, again, more acceptance. One of the things that we're really excited about is a direct-to-consumer campaign that we've just initiated, where we're showing that we are getting a significant level of response and new patients for practices that adopt the campaign, specifically geared towards educating patients on HPV and the risk associated with it, which is why you're achieving the type of patient that you want, which are predominantly females that are young families that obviously tend to make more of the decisions for the family when it comes to dental care. So just to give you some examples, again, I will tell you this has been really powerful and very well received. This is actually an ad that was well received by men. So I will tell you why now is the perfect time to jump on board, not only because of the value that it provides in terms of screening your patients better, not only because of the revenue potential, because of where VELscope's going. We just launched an AI study where the foundation of the AI, the program's already been established, and now we're just getting more patients into the study, or into, if you will, the program. That's going to allow us to hopefully have a product where we can put images, patient information into a program, and it will spit out a report that will provide greater guidance for our clinicians. And the great thing is there's significant tax rebates associated with participation as well, which, if interested, we can get into greater detail. So I will tell you, again, we've been around for many, many years, consistently been the head of the class when it comes to oral cancer screening, which is why it's been adopted by so many different DSO groups, from Heartland to Pacific to North American Dental Group. So with that, we thank you again for your interest. We look forward to further conversations. Again, you can find additional information on our website, but if you would like additional information, please don't hesitate to give us a call. Thank you and have a great day.